Welcome to the deep dive. Today, we're tackling some really complex and, frankly, potentially critical issues within the GI system.
We're focusing on the biliary tract, think, gallbladder, and the pancreas.
Right, these organs are so closely linked. When one has problems, especially inflammation, the other often follows, doesn't it?
It really does. We've pulled together notes from key nursing resources, aiming to synthesize the core knowledge you need.
So we're looking at the pathology, the key signs and symptoms, how these things are diagnosed, and critically, the management priorities, kind of giving you that essential roadmap.
Exactly. And our mission today is really to make these clinical concepts stick. The big connector, the thread running through all of this, is inflammation.
Inflammation, okay, yeah. And when these digestive systems essentially turn on themselves, you immediately see two major consequences: severe pain and a real hit to nutrition, because digestion just gets thrown off track.
Yeah.
Makes sense. And the main examples we're using today.
We'll be walking through cholecystitis, that's gallbladder inflammation, and acute pancreatitis, both classic examples of this inflammation concept in action.
All right, let's dive in with the gallbladder then. Cholecystitis. You mentioned inflammation. Are we usually talking about a blockage? Or can it happen other ways?
Well, the vast majority of the time, yeah, it's a blockage. That's what we call calculus cholecystitis.
Calculus meaning stones.
Exactly. Gallstones or cholelithiasis. A stone gets stuck, usually in the cystic duct, bile backs up, gets trapped, and becomes really concentrated.
And that concentrated bile is the problem.
It acts like a chemical irritant. It causes swelling, cuts off blood flow, that's ischemia, tissue can die, necrosis, and worst case, it can perforate.
Perforate, so burst.
Yeah, leading to peritonitis, a really nasty infection in the abdomen.
Okay, so the stone is the trigger, but the bile itself does the damage. And these stones are usually cholesterol-based, I read.
Primarily, yes. They form because of an imbalance in how the body metabolizes cholesterol and bile salts, but it's not always stones.
Oh.
You can get inflammation without stones, too. That's a calculus cholecystitis.
And what causes that?
It's usually linked to biliary stasis, basically, bile just sitting there stagnant. You see this in really sick patients. Think severe trauma, sepsis, major surgery, or people on long-term TPN.
TPN, total parenteral nutrition.
Wow.
So IV feeding.
Right. Because they aren't eating normally, the gallbladder isn't getting the signal to contract and empty, so the bile just sits.
That makes sense. It clarifies the stone versus non-stone causes. Now, risk factors. Everyone learns the 4 Fs, right? Yes. The classic mnemonic. Female, 40, fat, and fertile. It's a bit dated maybe, but still holds some truth. Why fertile? Hormones.
Yeah, hormonal changes, especially during pregnancy or with some birth control pills, can slow down gallbladder emptying. And obviously, obesity and a sedentary lifestyle are big factors.
Genetics, too.
Definitely. There's a higher incidence in certain groups, like American Indian and Mexican American populations.
Okay, but here's an interesting twist I saw in the notes. You'd think high-fat diets are the main culprit, but sometimes a low-fat diet can actually contribute.
It sounds backwards, doesn't it? But yeah, particularly with chronic cholecystitis in some specific groups.
Look who?
Think young, very thin women, maybe athletes or strict vegetarians. If their diet is consistently super low in fat, the gallbladder just doesn't get stimulated to contract regularly.
So it gets sluggish.
Kind of. It doesn't get its workout. The bile sits, and over time, it can lead to chronic inflammation. It's a bit of a paradox.
Interesting. Okay, so when inflammation does kick in, acute inflammation, what are we looking for? What are the big warning signs?
Pain. Abdominal pain and indigestion are core symptoms, but the key is the pattern. It's often triggered. Specifically by eating a high-fat or just a large meal, the gallbladder contracts hard against that blockage, and boom, pain. We call that biliary colic.
And this isn't just mild discomfort, right?
Oh, no. It's typically severe pain, usually in the right upper quadrant of the abdomen. Sometimes it radiates around to the back or up to the right shoulder blade.
Is this an emergency?
It absolutely can be. If that severe pain comes with signs of shock, like the patient looks pale, they're sweating, heart rate's racing, that's a critical rescue situation. You need to act fast.
Got it. What other GI symptoms might show up?
You often get dyspepsia, that's like heartburn or indigestion belching, which is eructation, flatulence, nausea, maybe vomiting. Pretty classic stuff.
And if the blockage is really bad or it's been going on a while, that's when we see the more systemic signs.
Exactly. When bile flow is significantly blocked, bilirubin backs up in the bloodstream.
Bilirubin. It's the pigment.
Right, it normally gives stool its brown color. If it can't get into the intestines, it builds up. You see jaundice, the yellowing of the skin, and icterus, yellowing of the whites of the eyes.
And the stool changes.
Yep. Since the bilirubin isn't reaching the large intestine, the stool loses its color. It becomes pale, almost clay-colored.
And the urine.
The kidneys try to compensate and filter out the excess bilirubin, so the urine becomes unusually dark, like tea-colored.
Okay, jaundice, clay-colored stool, dark urine, classic signs of obstruction. What about fat digestion?
Big problem there, too. Bile is essential for breaking down and absorbing fats, like dish soap, you know?
Good analogy.
Without enough bile reaching the gut, fats pass through undigested. This leads to steatorrhea.
Fatty stools.
Right. They look pale, bulky, kind of frothy, and they smell really foul because of the high fat content.
One quick safety note from the text. Older adults or patients with diabetes might not show typical signs.
That's a crucial point. They might not have that classic severe pain or even a fever. Sometimes the first sign in an older adult might just be sudden confusion or delirium. You have to be really vigilant.
Good reminder. So how do we confirm it's the gallbladder? Diagnostics.
The first go-to test is usually an ultrasonography of the right upper quadrant. It's quick, non-invasive, really good at spotting stones.
What if we need to see how well it's working?
Then we might use something called a hepatobiliary scan, or HIS scan. It basically tracks the bile flow and measures how effectively the gallbladder ejects bile.
It loves.
We'll check the white blood cell count, which is usually elevated with inflammation. If there's significant obstruction impacting the liver, you might see rises in liver enzymes, AST, LDH, alkaline phosphatase, and of course, bilirubin levels.
Okay, so we have a diagnosis. What are the priorities for management?
Manage the pain. Number 2, decrease the inflammation and rest the gallbladder.
How do we tackle the pain?
For that acute, severe biliary colic pain, we often need opioids. Morphine or hydromorphone are common choices. For milder pain, sometimes a strong NSAID like ketorolac can work.
And resting the system.
That means keeping the patient NPO nothing by mouth, prevents stimulating the gallbladder, and we give IV fluids to keep them hydrated, especially if they've been vomiting.
Are there non-surgical options to get rid of the stones?
There are a couple, but they're not for everyone. Oral medications like ursodiol can dissolve some cholesterol stones, but it takes a long time, like months or even years, and only works for specific types.
Oh, yeah?
There's also ESWL, extracorporeal shockwave lithotripsy, using sound waves to break up stones. But again, it's only suitable for smaller stones and patients who aren't obese.
So for most people, surgery is the definitive answer.
Yes. The gold standard is surgical removal of the gallbladder, called a cholecystectomy, and usually it's done laparoscopically.
The lap col. Less invasive.
Much less invasive than traditional open surgery. Smaller incisions, quicker recovery, less pain. It's really the preferred method now.
Any key post-op advice for patients?
Definitely. We tell them to avoid high-fat foods initially. Sometimes people develop post-cholecystectomy syndrome PCS weeks or months later with similar symptoms like pain or diarrhea, often triggered by fatty foods.
What about that gas pain?
Yes. The CO2 used during laparoscopic surgery to inflate the abdomen needs to be absorbed. If it lingers, it can cause significant shoulder or chest pain. The best remedy, get walking. Early and frequent ambulation helps absorb that gas much faster.
Excellent overview of cholecystitis. Now, let's pivot to the pancreas. You mentioned gallstones can trigger pancreatic problems, too.
They are actually the leading cause of acute pancreatitis, that or chronic alcoholism.
And acute pancreatitis.
Yeah.
It's a whole different level of serious, right? Like flavored.
Absolutely. It's a medical emergency. The core problem is autodigestion.
Self-digestion.
Exactly. Normally, powerful digestive enzymes made by the pancreas, like trypsin, lipase, elastase, are inactive until they reach the small intestine. In acute pancreatitis, they somehow get activated prematurely while still inside the pancreas.
And they start digesting the pancreas itself.
Yes. It's a chemical self-attack leading to massive inflammation, swelling, and tissue destruction.
The source material outlines 4 major destructive processes happening. Can you break those down?
Sure. First is lipolysis. The enzyme lipase goes wild, breaking down fat cells within and around the pancreas. This releases fatty acids, which then bind with calcium in the blood. This can pull so much calcium out of circulation that it causes severe hypocalcemia. That low calcium is a major metabolic red flag.
Hypocalcemia. Got it. What's next?
Second is proteolysis. Trypsin starts breaking down proteins in the tissue, which can lead to thrombosis, blood clots, and even gangrene.
Nasty. Third.
Third is necrosis of blood vessels. The enzyme elastase actually dissolves the elastic tissue in blood vessel walls. This can cause anything from minor bleeding to massive hemorrhage.
Hemorrhage. That sounds incredibly dangerous.
It is. This severe form, necrotizing hemorrhagic pancreatitis, or NHP, can lead to irreversible hypovolemic shock. It's a major cause of death in acute pancreatitis.
Wow. And the fourth process?
Is the inflammation itself. White blood cells rush in, causing more swelling. This can wall off areas of infection, forming things like a pancreatic abscess, basically a collection of pus, or a pancreatic pseudocyst, which is like an encapsulated collection of enzyme-rich fluid.
So the clinical picture must be dramatic. What does the pain feel like?
It's typically severe, constant, and has a sudden onset, usually felt in the mid-epigastric area or the left upper quadrant.
And the description? It's quite specific, isn't it?
Very. Patients often describe it as boring, not dull, but like it's drilling right through them, often radiating straight back or to the left flank or shoulder.
And positioning. Does anything make it better or worse?
Lying flat, supine makes it much worse. Patients often find some relief by sitting upright and leaning forward or curling into a fetal position, knees drawn up. That posture is a huge clue.
What else would we see on assessment?
Maybe jaundice, if a gallstone is blocking the bile duct too. The abdomen is usually very tender, often rigid with guarding, and you might hear decreased or absent bowel sounds. A paralytic ileus, the inflammation basically shuts down normal gut motility.
Okay, given the risks, hemorrhage, fluid shifts, shock, what's the absolute priority in care?
ABCs and supportive care. Preventing or treating shock is paramount. That means oxygen, continuous monitoring of vital signs, watching that blood pressure and heart rate like a hawk.
Right, for signs of shock, hypotension, tachycardia.
Exactly. And aggressive IV fluids are critical. We need large volumes of isotonic fluids like normal saline or lactated ringers to combat dehydration and the massive fluid shifts occurring into the abdominal cavity, what we call third spacing.
And electrolytes, you mentioned calcium.
Absolutely crucial to monitor and replace electrolytes, especially calcium and magnesium, which can plummet due to that fat necrosis, the lipolysis we talked about.
How do labs help confirm the diagnosis here?
The key markers are pancreatic enzymes in the blood. Serum amylase levels shoot up quickly, usually within 12 to 24 hours, but they also tend to come back down within 2 to 3 days.
So if someone waits a few days to come in,
Amylase might be normal already. That's why serum lipase is often more helpful. It might rise a bit later than amylase, but it stays elevated much longer, sometimes for up to 2 weeks. It's a more reliable indicator if there's been a delay.
okay, amylase and lipase, what else?
We'd also see that decreased calcium and magnesium we mentioned, often an elevated white blood cell count, maybe elevated glucose, and potentially liver enzymes if there's biliary involvement. Imaging like ultrasound or CT helps visualize the pancreas and look for causes like gallstones or complications like pseudocysts.
And the core nursing principle is still rest the pancreas.
Absolutely. Strict NPO status, nothing by mouth. We want to minimize any stimulation of pancreatic enzyme secretion.
What about pain control? The boring pain sounds agonizing.
It is. Aggressive pain management is essential, usually with opioids, often via a patient-controlled analgesia, PCA pump, to give the patient better control.
Do we always need an NG tube?
Not always. It used to be routine, but now it's generally reserved for patients who have persistent vomiting or if there's evidence of a paralytic ileus or significant abdominal distension, just to decompress the stomach.
How do we know when the gut is starting to work again?
Well, we listen for bowel sounds, but the most reliable indicator, the action alert from the sources, is actually the return of peristalsis, evidenced by the patient passing flatus or having a bowel movement. That's the real sign things are moving.
Okay, if they're NPO for a while, how do we manage nutrition?
If someone needs to be NPO for more than a day or two, we need to provide nutritional support. The preferred route now is actually enteral nutrition, feeding through a tube placed into the jejunum, bypassing the stomach and duodenum.
Why jejunal feeding over TPN?
It's generally safer and has fewer complications. It helps maintain the integrity of the gut lining, reduces the risk of infection compared to IV feeding, and avoids the metabolic issues like hyperglycemia that often come with TPN. TPN is reserved for when the gut just isn't usable.
Okay, that covers the acute crisis. What about when pancreatitis becomes a long-term problem? Chronic pancreatitis.
Chronic pancreatitis is a different beast. It's a progressive, destructive disease with periods of remission and then flare-ups. The key feature is irreversible damage, fibrosis, and calcification replacing healthy pancreatic tissue.
leading to permanent loss of function.
Exactly. Both exocrine digestive enzyme production and eventually endocrine function, meaning insulin production.
What's the main cause here? Still gallstones?
Less so for chronic. The number one risk factor for the most common type, chronic calcifying pancreatitis, CCP, is overwhelmingly alcoholism. Other causes include genetic factors, obstructions, and autoimmune issues.
How does the pain present differently in chronic versus acute?
The pain can still be significant, but it's often described differently. More of a continuous, gnawing, burning, dull ache rather than that super intense, acute, boring pain. Tenderness might be less intense too. Managing this chronic pain is a huge challenge, often leading to opioid dependence issues.
But the defining feature is that loss of function, right? Especially exocrine.
That's the hallmark. As the pancreas fails to produce enough digestive enzymes, malabsorption becomes severe.
So we see that statiry again.
Yes, but often much more pronounced and persistent than in gallbladder disease. Those pale, bulky, frothy, foul-smelling fatty stools become a daily reality. This leads to significant weight loss, muscle wasting, and deficiencies in fat-soluble vitamins.
And eventually diabetes.
Yes, as the endocrine function fails, the islets of Langerhans that produce insulin are destroyed, leading to diabetes mellitus.
So managing chronic pancreatitis shifts focus. It's less about acute rescue and more about managing insufficiency.
Precisely. Pain management is still key, often trying non-opioids or other modalities where possible. But the cornerstone of treatment for the malabsorption is pancreatic enzyme replacement therapy, or PERT.
PERT, replacing the missing enzymes.
Exactly. These are capsules containing amylase, lipase, and protease. The critical teaching point for patients is that they must take these enzymes with all meals and snacks, not before, not after, but with the food.
And they shouldn't chew them.
Correct, especially the enteric-coated ones, as they need to reach the small intestine intact. The effectiveness of PERT is judged by monitoring the patient's stools. Ideally, they should become less frequent, less fatty, and more formed.
What about diet? It must be challenging with the malabsorption.
Extremely challenging. Patients actually need a very high-calorie diet to compensate often 4,000 to 6,000 calories a day.
Wow. The focus is on high carbohydrate and high protein intake, but it needs to be relatively low fat, even with enzyme replacement, as fat can still trigger pain. And absolutely crucial, avoid alcohol and other gastric stimulants like caffeine.
Yeah.
Okay, finally, let's touch on the most serious diagnosis, pancreatic cancer, often caught late, sadly.
Yes, it has a very poor prognosis, largely because it's usually diagnosed at an advanced stage. The pancreas is located deep in the body, so tumors can grow quite large before causing noticeable symptoms.
What are the major risk factors we should know? The sources mention a table 54.6.
Right. Key risk factors include cigarette smoking, that's a big one, chronic pancreatitis itself, diabetes, mellitus, obesity, older age, and being male.
And the symptoms are often vague initially.
Very vague. Things like dull abdominal pain that might radiate to the back, unexplained weight loss, loss of appetite, fatigue. Often the first really specific sign is jaundice.
Jaundice again. But here it means the tumor is likely advanced.
Usually, yes. It means the tumor, often in the head of the pancreas, has grown large enough to obstruct the common bile duct. New-onset diabetes in an older adult without other risk factors can also be a warning sign.
How is it diagnosed? No simple blood test, I gather.
No single definitive blood test. We monitor tumor markers like CEA and CA19-9, but they aren't specific enough for diagnosis alone, more for tracking response to treatment. Diagnosis relies heavily on imaging CT scans, ultrasound, sometimes ERCP or endoscopic ultrasound to visualize the tumor and get biopsies.
And treatment. Is surgery an option?
Surgery offers the only potential for cure, but unfortunately, only a small percentage of patients are candidates because the cancer has often spread by the time it's found. For tumors confined to the head of the pancreas, the major surgical option is the Whipple procedure.
Whipple. We hear about it as massive, right?
It's one of the largest and most complex abdominal surgeries performed. Officially, it's a radical pancreaticoduodenectomy.
What exactly gets removed?
The surgeon removes the head of the pancreas, the entire duodenum, the first part of the small intestine, part of the jejunum, the next part, sometimes part or all of the stomach, the gallbladder, and nearby lymph nodes. Then everything has to be meticulously reconnected. The remaining pancreas, the bile duct, and the stomach are all stitched back to the jejunum. Multiple anastomoses, multiple points of potential failure.
Which makes post-operative care incredibly high risk.
Extremely high risk. These patients require intensive care monitoring. The single most common and dangerous complication we watch for is a fistula.
A leech.
Yes, a leak from one of those reconnection points, biliary, pancreatic, or gastric. These digestive juices are highly corrosive and can leak into the abdomen, causing chemical peritonitis, sepsis, and hemorrhage. It's devastating.
What else are you watching for immediately post-Whipple?
Hypovolemic shock is a huge concern. There can be significant blood loss during the surgery, plus major fluid shifts afterwards, especially in patients who are malnourished beforehand, which is common. So we're constantly monitoring blood pressure, heart rate, urine output, and CVP, if available. Also watching for hemorrhage, infection, glucose control issues, since part of the pancreas is gone. It's intense.
It really sounds like it. That brings us through the full spectrum, from gallstones causing simple inflammation right up to this incredibly complex cancer surgery.
It does. We've covered cholecystitis, think stones, the 4Fs, lap shoal as the fix, then acute pancreatitis, that terrifying autodigestion, the boring pain needing NPO and fluids, and finally, the long haul of chronic pancreatitis with Purite, and the sobering reality of pancreatic cancer and the Whipple procedure.
So wrapping this up, here's something for you, the listener, to think about. We've seen how often these conditions are linked to lifestyle fat intake, alcohol, smoking. And we've traced the path of inflammation, that core concept, from a simple stone blockage to autodigestion to chronic scarring and even cancer.
Right. So the question is, how can really internalizing that progression of inflammation help you in your practice? How can it sharpen your focus on preventative patient education, catching issues earlier, and understanding the physiological stakes involved for your patients? A really vital connection to make. It highlights how crucial our role in education and early detection can be.
Indeed. A huge thank you, as always, to the Last Minute Lecture team for providing the framework and source material for this deep dive.
Yes, thank you. And thank you for joining us.
Until next time, keep digging deeper.